Christine is a research assistant professor of human health and the environment with the joint appointments at the Rubenstein School of Environment and Natural Resources and the College of Medicine. She has a PhD in Environment and Resources from the University of Wisconsin and a Master of Science in Conservation Biology from the University of Minnesota, and her bachelor's in Natural Resources from Cornell. Fun fact, she grew up on a small organic dairy farm in New York.
Hey. She had this map, and she kind of went around and showed everybody where she would come from and like the pivotal experiences in her experiences that led her to where she is. And so here's my map. It's not showing up, but I do have some pivotal experiences. So I'll show those to you. So somewhere here in upstate New York is the dairy farm where I grew up on, a small organic dairy farm. And this was important to me for a couple of reasons, right? So I grew up in this situation where I was outside all the time, I'm experiencing nature, and that gave me a very early interest in studying the environment to begin with. And we'll return here in a minute, but I went away to, wow, my pages aren't showing up. They're showing up here, but not here. We'll just see what happens if I click through them all. All right. This is my map. So then I went to Cornell University. When I was at Cornell University, a few pivotal things happened. Welcome to Ellen. My map just isn't showing up, just so you know what's happening. So it's not showing up.
It's really zoomed out.
Yeah, I'm not sure what's happening. So we're just not working here. So anyway, I went to Cornell and studied natural resources. And while I was at Cornell, I was a junior. The end of my junior year, my father was diagnosed with cancer. And so I was kind of observing his cancer care through this lens of environmental studies, ecology, natural resources, and we had a few conversations about what's the impact of the medical process on the environment. And so very early on, my junior year, that seed was planted. And I went through his process of cancer treatment, eventual hospice care, and he died about 2 years after his initial diagnosis. So that whole process was very pivotal for me in trying to understand the beginning interest in environment and health. I traveled around the country for a bit, did some conservation work, ended up deciding to go on for my master's degree in conservation biology from the University of Minnesota. Many of you were here last week and got to meet Steve Pulaski. He was one of my professors. Not an advisor to me, but he was one of my professors. And I studied in his class social and economic aspects of conservation biology. And that was one of the first instances where I was really being drawn into the idea of the social side of conservation. And from there, I went on and became an environmental planner at the Metropolitan Washington Council of Governments in Washington, D.C., and I worked on the restoration of the Anacostia River. And there I was getting more involved in like the human aspects of conservation. And at the same time I started teaching at Georgetown University. I was an instructor for environmental sciences. So I was getting this early passion for teaching combined with these experiences in the social aspects of environment. And I really decided to return. I wanted to go back and get more education, so I went back for my PhD at the University of Wisconsin. And while there, in the first couple of weeks of speaking with my advisor, I said to him, I have this idea. It's been bothering me for around that time, it was about 10 years. This question of environment and health and medical care, and what's the impact. And he said, write up a 2-page report that just gives a background of what literature might we pull on for this. And so I went out, actually found quite a lot of possibility in the literature. There were some loose ends that hadn't been tied together yet, but it looked like great possibilities. So I brought that paper back to my advisor, Mike Bell, and he's a great person because he took that 2 pages and he said, let's go with this. this looks like there's some great potential. And so the next 5 years of my life, I spent in an ethnographic study of conventional, palliative, and hospice care for end-of-life cancer patients, comparing the differences between those different settings in terms of the medical resources that are used, the social aspects that are governing the flow of those resources. And then after that, I ended up here at the University of Vermont. And so I'm going to tell you a little bit about what I'm going to talk about today. So the title of my talk is Flourishing in a Time of Flows. What is the role for environmental health social sciences? So to start off with, what is flourishing, right? Like, this is a word that we hear about. People might have different definitions, but we're seeing it increasingly, even some of like Millennium Ecosystem Assessment. United Nations uses this term a lot. And the first time I ever came in contact with this term in the concept of sustainability was I was at the University of Wisconsin, and it was the final year of my doctoral research, and I was acting as the coordinator for the sustainability program for the university. So basically, the University of Wisconsin is about 70,000 people, including staff and students. So it's a small city, and so I was there helping to coordinate their initial efforts at getting sustainability up and running. And I was one of the co-leaders of the health working group. Myself and Jonathan Patz were working together to get this group of people to understand like what could health mean in this context of sustainability on the campus at the University of Wisconsin. And David Rakel is an integrative medical physician at UW Health, and he proposed that this was the term that is our goal. We want flourishing people, we want flourishing health, we want flourishing ecosystems, and so that's what became the foundation for the report that health working group went with for what is our goal in this context of sustainability at the campus level. So that stuck with me very much, and I use it today when I'm thinking about what my goal is for research. I'm really, at the very big picture level, the things that I'm doing are trying to move us towards sustainability with this idea that sustainability is this balance of ecological flourishing plus human flourishing. So what does that mean? How do you measure ecological flourishing? Lots of different ways people are doing this. Thinking of resilience, biodiversity, ecosystem services, ecosystem functioning. There's lots of different metrics. This is no longer my area of expertise. It may have been 10 years ago when I was really focusing on conservation biology. But I have enough background in this area to at least be familiar with some of the context of how people are looking at this currently. I've moved more into the human flourishing area with a focus on health and happiness, and there are some specific metrics that people measure here. In terms of health, we think about physical, mental, and social health. This is the World Health Organization's definition of health from 1948, that health is a complete sense of physical, mental, and social well-being, and not merely the absence of disease or infirmity. And happiness, there's a lot of happiness literature out there. The Genuine Progress Indicator is a lot about happiness. I really like the work that Nick Marks has been doing in the UK, and he comes up with 5 key metrics that he sees as the areas for measuring happiness. And these are social connections, physical activity, lifelong learning, helping others, and having a mindfulness or awareness about your surroundings, your relationships with other people. So this is the general context that I use when I'm thinking about my approach to the work that I do. And one of my areas of research right now is really looking at this idea of how does ecological flourishing impact human health? And just to give you an idea of some work that I'm doing in that area, I'm really looking at the health benefits of nature contact. And a lot of this work has been revolving around work at the Vermont Cancer Center. And in particular, we have a healing garden over there. We're designing some research studies. I had an undergraduate student last semester who went in and did her senior thesis on what is the current use of that healing garden, what are opportunities to expand the benefits that are coming from that healing garden, knowing that the staff were saying, we have this great garden here, but nobody's using it. Why is this? And so we've identified some specific reasons why people aren't using the garden. How can we get people in there more, knowing that there's this great literature suggesting that in general we derive great benefit through both stress reduction and attention restoration. Are these terms that people are familiar with? Stress reduction is definitely familiar. Attention restoration, our ability, right? Everybody needs some stress reduction. And then attention restoration is the idea of returning focus after you've been working on something for a long time. You start to lose your focus. How can you come back to that focus again? There's some great work done specifically by the Kaplans, Rachel and Stephen Kaplan at the University of Michigan, have been pioneers in this area. And Roger Ulrich is also another person who has a lot of research in this particular area. So I'm building one area of my research program in this specific area, but I want to talk more about the other things that I'm working today because I think that there's a lot of potential for collaboration with folks here in Gun in particular. Before I say that, I'll say another area in particular is this idea of how do we improve nature contact and measure the impact of nature contact among cancer patients and cancer survivors. And this is an area that I'm working on specifically with Susan Lakoski, who is, she's a cardiologist who works with cancer patients, and she's been working with this group called Steps to Wellness here on campus. And Kim Dinnis is the leader of Steps to Wellness, and they have this program. It's 12 weeks where cancer patients go and they basically get physical exercise. They go walk on the treadmill, lift weights, that sort of thing. So we want to understand, after that 12 weeks ends, we know that adherence drops off. Why is that? Maybe people don't have access to a gym, maybe it's too hard to just continue on your own. We're trying to figure out, are there social aspects of that could help people adhere to their exercise regimen after the program ends? But also, from my perspective, could we instead have some of that exercise outside in a natural setting, which would help both improve potentially stress reduction, but also allow people to have better access, right? If you don't have a gym membership, that might be why you don't adhere to exercise after you're done. But if you have access to a map of trails in your area, maybe you would continue walking, that sort of idea. So that's that general area of research that I'm working on. So here we are, back at this question of flourishing in a time of flows. So flows are this idea of movement, the movement of something, and we tend to think about this in terms of people, materials, ideas, moving, network society. I'll talk about that here. My background, when I was doing my doctoral work, I was really focusing on sociological theory. And so these guys, Manuel Castells and John Urey, really were pioneers in this idea of the sociology of flows. And what they were saying was that we are a networked society. We have to start thinking about sociology in new ways, whereas previously we thought about the movement of materials and ideas as being bounded by nations, right? And so a lot of the governance of the movement of things came from the nation state. But they were suggesting that now we're in a much more interconnected global society. We have to think about different ways that the movement of these flows is being governed. And then Arthur Mall and Gert Sparreveren picked up on this idea, and they said, let's develop a more specific sociology and theory about environmental flows, knowing that a lot of resource extraction is the way we've been thinking about things. We pull them out, natural resources, we pull them out of the ground, we move them through a life cycle, and then we dispose of them in the end. And they said, let's think of that in a more networked way and trying to specifically understand what are the social aspects that are governing the movement of those flows. So this is the thing that I picked up on and said, let's see how flows work in these medical settings. So for this area of my research, I'm really focusing on how do our health behaviors, oh, I forgot, my little pointer doesn't work, our health behaviors, how do our health behaviors influence ecological flourishing because of that idea of extraction and disposal of things, the movement of materials through space and time. And so here, really, I look at the socio-ecological impact of medical care. And this can be a variety of things. One of the areas I'm really interested in right now is this idea of specific diagnoses. So for example, ductal carcinoma in situ is stage 0 breast cancer. And we know that about 98% of women who are diagnosed with stage 0 breast cancer are alive 15 years later after diagnosis, regardless of what treatment choice they follow. And yet 40% of women with this diagnosis are having mastectomy. Why is that? The difference being that you have options between typically either a lumpectomy, which is a smaller, less invasive surgery, the potential for some radiation, and the potential for some estrogen therapy, depending on the tumor itself. So when you compare all the resources that are needed for a lumpectomy to all the resources that are needed for a mastectomy, you can see that there's actually a pretty large potential cumulative ecological impact simply from the amount of materials that are needed for these different types of therapy. So when you're looking at that sort of model, you can see an opportunity for comparative analysis to understand what's the difference in here, what are the social factors that are driving the medical decisions between people getting a mastectomy versus people getting a lumpectomy, knowing that the outcomes for people are actually better when you get a lumpectomy compared to when you get a mastectomy. People who go for the mastectomy have higher risk of weight gain. It increases their chance of cardiovascular disease because of weight gain, that sort of thing. So what are the factors that are driving those choices? So that's one potential area. Another potential area, oh yes?
Does the range of treatments include no treatment?
It doesn't right now. So this is a big question nationally and internationally. The question is, should we provide watchful waiting as an alternative? And right now, watchful waiting is not recommended because, well, here's another piece of that story. So we know that 70% of ductal carcinoma in situ, stage 0 cancers of the breast, 70% of them will never become clinically relevant. You could have it your entire life and it won't kill you. The problem is we don't know which 70%. So 30% could become invasive and could become problematic and could kill the woman if left to continue on and become invasive. So right now we don't have the diagnostic tools available to distinguish between those tumors that will become invasive and those that won't. So the standard practice is to offer lumpectomy or mastectomy. And then the question is, why are 40% of women requesting the mastectomy? And there are some cases where it's appropriate. I have some really great advisors over at the College of Medicine who are working with me on these questions. There are definitely some cases where it's appropriate because it depends on the histology of the tumor itself. And yet there are some cases where we see, and there's been some great literature on this as well, that some women really would prefer to have mastectomy because then they don't have to worry about it anymore. And that's a huge piece of that, right, human health and well-being. How do we achieve happiness? Could you achieve happiness as a woman if you don't have a mastectomy, and then are you going to be continually worrying about that? So there's a lot of complexity to these types of questions. Yes?
You keep saying women. I'm wondering if you're also including men. Do you have a cohort for men with breast cancer?
We don't. There are definitely cases of men who get breast cancer. It's such a very small population size that it's not included in the research that I'm doing.
Okay.
It's less than 1 per year in Vermont.
Mm-hmm.
So we wouldn't be able to actually get any solid data on that sort of component.
So you are just looking then at Vermont? You're not looking, these are all
Right.
breast cancer cases in Vermont?
Currently, yes.
Okay.
Yeah, that's the proposed idea,
Okay.
yes. So the other area that I'm really working on a lot right now is pharmaceutical waste. And so this area of research came about through my doctoral work where I was seeing that pharmaceutical waste is problematic because of governance factors in terms of one of the greatest quotes I've ever gotten in interviewing and participant observation was from a pharmacist, and he was in an end-of-life healthcare setting, And he said, well, yes, pharmaceutical waste is a concern for the environment, but the DEA scares us more than the EPA. The DEA has guns, they can fine you, and the EPA, what can they do to you? And so it became this, pivotal moment for me saying, oh, wow, there's this governance factor. So I've been delving down into this area quite a lot. Right now, I'm working on a project to understand pharmaceutical waste, the impacts on Lake Champlain in particular. I've partnered with Pat Phillips, who is at the USGS, and we have a bunch of samples. Any day now, I keep hearing we're gonna get the data back from the National Water Quality Lab. We sampled for a 10-day period in Lake Champlain to understand the effluent leaving the wastewater treatment plant. We're looking at the specific pharmaceutical concentrations in that water, and trying to understand if there are different social factors that we can pinpoint some of those pharmaceuticals to. At the same time, so we collected the data over the 10-day move-out period for students because it's about 10% of our population moves out of the city. And so you might be able to see a drop in the pharmaceuticals just alone. You would expect potentially to see a drop of estrogens from birth control pills, that sort of thing, are among the major pharmaceuticals you would see in this age population, but also the question of pharmaceutical waste. So I also have currently survey, you might be seeing a survey come out in the next couple of weeks, asking students about their medication waste disposal. Have you disposed of waste in the past year? How did you dispose of it? Because there are different guidelines people might not even know. In the past, people were directed to dispose of things simply by flushing it down the drain. Because the concern in the past, and somewhat still today, has been this question of drug diversion, people getting a hold of drugs that are not their own, becoming sick from it, or narcotics in particular, the possibility for selling drugs on the black market, that sort of concern. So looking a lot in pharmaceutical waste to try to understand what are the governance factors that we can target for points of intervention for helping to improve waste disposal opportunities. There's the 2 national drug take-back days every year. So this has been interesting to me too, just trying to look at the data. How do we know that we have like a waste problem? So last year alone, there were 695 tons of prescription pharmaceutical waste collected at national take-back days. So you know that that's not the total amount that could be out there, because not everyone feels comfortable bringing that waste into a take-back day. Either it might not be convenient for people. At the same time, those are run by drug enforcement folks, so you're going to have police presence. So people might not feel comfortable bringing their drug waste there for whatever reason. So we know there's a potential to have more drug waste out there. How do we help understand ways that people could dispose of that properly? And at the same time, working with, actually Alexandra and I are working on this question, interviewing physicians, interviewing pharmacists to understand like what's the upstream component of this. Where is this extra drug coming from? If we have so much being wasted, why is that happening? And a lot of it has to do with the potential for just, buy in bulk, right? Like in our society, you can buy drugs in bulk. Not necessarily the prescription drugs, but over-the-counter drugs for sure. Prescription drugs, there's concerns about the potential for, you have to write a prescription that covers the right amount of time, so that there's a convenience factor. So that could be a component of this. How do we work with physicians to limit the amount of prescriptions that are being written? So those are all questions that we're asking right now in that area of research as well. But so, all right, so here's a little bit of flourishing, a little bit of flows. So what's the role for the environmental health social sciences in kind of addressing some of these concerns and questions? So basically, I think that we can, through the environmental health social sciences, so what does that mean? First of all, environmental health, right? The study of human health and the environment, lots of different folks working on these areas. Social sciences, anything from sociology, anthropology, history, could be a component of social science depending on how you're looking at it. Lots of different ways to find places where we can intersect and bring our knowledge together to help reduce some of the concerns that we're seeing. So methodologically, I use quality, and I see great value in mixed methods. I know that numbers really move government, numbers move the dollars, and at the same time, the stories, the narrative, that qualitative piece is what moves people. So I see the great possibilities for, finding ways to use these mixed methods, right, with the pharmaceutical research, getting that solid data on what are the actual concentrations of pharmaceuticals in our waste, and then the social aspect of talking to pharmacists, talking to physicians, and trying to understand where is this waste coming from. So having that mixed methods approach. Theoretically, I think we have lots of possibility for learning from the social sciences, and I'll show you a little bit more about that in a minute, with the main point being how do we use these methods and these theories to help identify those points of intervention where we can have a true impact that will help us get closer to this idea of flourishing in our society. So when we're thinking about identifying these points of intervention, I like to think about the intravenous bag. Why in the world would I think about the intravenous bag? Because this is where I started off with this idea of flows, right? So this idea of materials that are moving through the environment. And what I came to through some of my earlier research was the idea, all right, so you have the upstream, and then at the point of care, you're using these materials, and then downstream, you dispose of them. That's your traditional idea of the flow. When thinking about flows more broadly, though, I started to see that there are actually 3 dimensions of these flows. There's the material dimension. There's this intravenous bag itself. It's an actual object. You can hold it in your hands. It is the material. But there's also information that flows along with this, or potentially doesn't flow along with this. I'll talk about that in a moment. But the information could be anything from what's in that bag, which is important because if it's a hazardous substance, you need to know what's in it so you can handle it appropriately, to information about where did it come from, how do I dispose of it properly. If you don't have that information, that can create a problem. And there's an identity dimension as well. So these are the 3 dimensions. Identity being that there's a person who made that bag. There is a place in the environment where the components of that bag came from. And if we think of all 3 of those components, material, information, and identity, we can start to see that there's a lot more complexity to this idea of flows than the ways that we've been thinking of it before. And we need to look at all 3 of those areas to identify the different factors that are governing it. And so what I propose is that problems arise in 3 different areas in the governance of these 3 different dimensions, and particularly the visibility or invisibility of the dimensions, mobility or immobility, and the flexibility or inflexibility of governance. Let me explain a little bit about what I mean here. So basically, if you sat down and did this, and I would love for this to be a thought experiment when we open up in a minute for conversation, you could fill in every box of this table to try to get a sense of, all right, when is there a material that has a problem with visibility that is causing some environmental or human health harm? When is there a problem when information has a problem of mobility? It's an immobile information, right? There are times when you might want any one of these dimensions to be invisible or to be immobile. For example, material, right? A very material thing right now is Ebola. Ebola is a material pathogen, right? And it moves. You want it to not move. You want it to be immobile. The concerns surrounding Ebola right now are that it is moving. So we want to find a way to make it immobile. A concern about information, when you think about it in terms of healthcare, you don't want your personal health information to be jeopardized in some way. So we have HIPAA, right? The Health Information Protection and Portability Act. You want your information to be immobile. You don't want people to find out about it. And yet at the same time, there are problems on the flip side as well. There are times when we want to have visibility when we don't. So for example, in my research, I have seen that a lot of the times we have staff exposures in the hospital to hazardous substances, to infectious waste, because there is a problem with the visibility of the information or identity piece. So for example, in the hospital, you'll see disposal containers for municipal waste, right, just things that you would throw out in your household trash, and then you have containers for the red bag waste, the infectious waste. And there have actually been some problems that I have seen in my own observations where people are disposing of things in the wrong bag, right? There's infectious waste ending up in the municipal bag. A very basic problem with that is that the bag itself, right, these black garbage bags of the municipal waste stream, once you close it up and tie it, you can't see in it. It's actually physically invisible to see that there might be infectious waste in there. I was taken down to a loading dock at a hospital where I had been working at previously, and the environmental staff person I was working with wanted to show me, for example, let's just go through like 10 bags and see what we find. So she's opening up these bags, municipal waste stream, and we found in the third bag, I think it was the third bag that we opened up, we found infectious waste. It was this large container that had been used to suction mucus and fluid from someone's lung, and it was in the municipal waste stream. How did it end up in there? Right? And she's like, oh, it happens all the time. That's why I brought you down here. I knew we would find something. Right? And you're kind of like, wow, too much information that I didn't want to see this myself, but this is great to be learning about this stuff. And so when we have these sorts of problems of the actual material is invisible, but also the person who threw that infectious waste in the wrong waste stream, why was that? It might have been a problem with the invisibility of information. Either the person wasn't trained properly for some reason and didn't know that they were actually supposed to put it in the red bag, not the black bag. But it also has a lot to do with the invisibility of identities, right? Because the person, it was typically a nurse who would be handling that waste and deciding where it went in the hospital where I was working. So that nurse did not have social connections to the person downstream from her. They would pass in the hallway, nobody knew each other's names. People used separate elevators. There was a pathway, a flow of people that separated each other. So nurses were not aware of the housekeeping staff. Because of that problem with the visibility of the identity of the next person downstream from you, maybe you're less likely to consider that if you put it in the wrong waste stream, it might hurt somebody, it might have an impact downstream. How do we make those people more visible to each other? Could that have a positive impact? When we're thinking about problems of mobility, we think about, just in general, the immobility. So when we think about the difference between visibility and mobility, it's kind of like a gray area in some situations. But really what I'm trying to say is that in the problems of visibility, there's information or identities, they're there, you just don't see them. When you're thinking about the mobility of things, it's more like the information and those people and places, they don't come along with that material, right? Like if you're thinking about that PVC bag or nitrile gloves, I did a lot of work trying to figure out where do nitrile gloves actually come from, and I called up the manufacturers, where is this material originating, what's the source? And okay, they could get me as far as Malaysia. And then we didn't know, like the people who were working there in the factories, the people who were like my point people, they couldn't get me farther than that. That information is immobile. You can't even figure out where is the, where's the source of that oil in this case, because it's a petroleum derived product, those nitrile gloves. We don't know where it came from. Didn't even move. How would the system change if we knew where those materials came from? How would the system change if we knew the actual people who were responsible for the creation of those materials? And then in terms of the problem of flexibility, this really was brought to light with that idea of the pharmaceutical waste, DEA versus the EPA. So the DEA has been very inflexible up until very recently, just within the past month or 6 weeks. The DEA has changed the possibility that now opens up the potential for pharmaceuticals to be returned to a pharmacy instead of a national take-back day. So over the next year, we're going to be watching the potential rollout of new opportunities for people to just take any leftover medicine that they have back to the pharmacy. But before that, it was a very inflexible sort of system because the DEA is so concerned, the Drug Enforcement Agency is so concerned about narcotics diversion that they want to make sure that the waste is taken care of, put it down the drain, get rid of it as quickly as you can, because we're more concerned about that public health aspect than the public health and environmental aspect that might happen should we wash these things down into surface waters through the drain. So there's some great potential for something becoming less inflexible, things are becoming more flexible in that area, but this is the spot where I was first thinking about this idea of flexibility. So in general, I think that this invisibility and immobility of information and identity is the area to really think about, to focus on. When we're thinking about those 3 dimensions and the different barriers to movement, thinking about invisibility, immobility of information and identities, something that we could have an impact on in a lot of different areas. To minimize those impacts that are resulting from these situations, trying to develop policies that support mobility and visibility of information and identities, and then making sure that the policies are flexible enough to respond to new concerns, for example, pharmaceutical waste in the surface waters. All right, that's it for now. Please let me know what questions you have, and I would love to have a conversation. Yes?
So when you discussed identity, it seemed to be, you could think of it as the source, which brings up question, where is it going? Why is the ultimate destination not part of the identity?
Right, and it should be that whole flow. So I didn't mean to suggest that it's just upstream, but that entire, like if you're thinking about it in a life cycle sort of situation, thinking about the upstream, but also the downstream, absolutely. Where does it go? Who are the people, right? Because for a lot of these things, when we're thinking about hospital waste, infectious waste, hazardous waste, and the resulting ash ends up in hazardous waste landfills. And those facilities, both of those types of facilities are traditionally sited in areas where people are either minority communities or socioeconomically disadvantaged. So those people, how do we make those people more visible? And there's been a lot of work in that area.
So I'm having difficulty with that word identity, and I wonder, is it not possible to think of it simply as source and destination?
Well,
Source.
potentially, but there's the identity. So I'm using the word identity, and this is fine because it's kind of still in the baking mode. So let me know if identity isn't working for you. Let me know.
I don't really get it.
Okay, so the identity piece is really about both the people and the places that flow has been and will go. So thinking of the upstream piece, there's a place, a physical place where the natural resources were extracted, and there are people who actually did that. So those are the identities, right? The identity of that place, the identities of the people. And then there is a place that it moved to, right? It went on a truck and it was driven somewhere and there was a person involved in that. That's part of that identity. And then you move further down, there's a nurse who handles that material and who is in a specific physical location. If they're in the United States, there are certain standards about how to handle certain chemicals or chemotherapy, that sort of thing. Who's that nurse? What is that place? How do those situations, those social factors govern that movement in that place with that person? And then further down the line, where does it go? Where does it end up? What does the facility end up with? Is it an incinerator? Is it a landfill? Who are the people who are touching and managing those things? Is that clear?
Yes, it's a very big picture.
But the identity is always a person. It's never the object itself.
Identity is the person and the place,
Person and
never
place.
the object
Okay.
itself.
All right.
Yep. Taylor.
So you said the phrase life cycle analysis?
Yeah.
Okay, so I listen to you and I think life cycle analysis. Well, so I'm glad you said that. Lots of work on food and consumer products. Life cycle, like the total impact on a variety of axes of a kind of cradle to grave thing. So I just wondered if you're still forming this sort of two things. If you're still forming this sort of framework of things, it seems like that's a super well-developed area of research, both biophysically and sociologically. So are there frameworks that apply to the medical seen from the food or iPad scene. And then the second one is, has anybody actually done kind of quantitative, empirical life cycle assessments of a bag of chemicals or a bottle of pills?
Now that I've seen, so I haven't seen any empirical life cycle analyses of medical materials.
It seems like a huge
Right?
opportunity.
Yes.
Because the methods are there,
Right.
super well worked out.
Absolutely, right? Because you can take it back to the paper versus plastic bag, right?
Yeah,
Like
right.
any of those things. Yeah. So there's definitely opportunity. There's huge opportunity for applying all of those different methods. And I agree with you. Life cycle analysis, very well established. Sociological aspects of that, very well established. The idea of the environmental flows is more recent in the way of sociology looking at life cycle analysis. They don't necessarily talk about life cycle analysis in the flows literature. So that's, why is that? I'm not sure.
Yeah,
Because it's very parallel in a lot of ways, but I think it's because they're thinking more about the governance, what are the social factors, what is the political economy, what are the cultural behaviors that are governing the movement, rather than looking at the traditional LCA is much more about the material and what are the numbers associated with it. And that might be the distinction. The environmental flows is more about what's moving these things, who are the people involved, what are the policies involved. Bob?
I have a response to your question about why it hasn't been studied. I have a fight with my wife about turning off lights. I bike up the hill. I think I should write another email to the traffic people in Burlington about their stupid system of lights. It's so threatening to pedestrians. And then I go see the doctor, and I'm old, and plastic is flying everywhere, but I am scared. And so I say, that's one place where I'm not going to mess around. So I'm thinking that this is one where maybe even hardcore environmentalists would just say, wow, this is about mortality. Let's back off.
Yeah, I've come across that. So for my doctoral work, I was really looking at end-of-life medicine, right? Like cancer patients who were terminal. They were in like the final 6 months of their lives. And these questions came up just a few times. I'm surprised that they didn't come up more often, but there's been some literature. Andrew Jameton has written in this area a lot, and he has another person, now I'm forgetting, I think his last name is Carrick, C-A-R-R-I-C-K. They're both bioethicists. And they're having this conversation through the literature about should we even be considering environmental aspects of medical care, because you're kind of putting human health and well-being against the environment. And should we be more concerned in the medical arena about human health and well-being? And Andrew Jameton, I'm very much on the side of his argument saying, but, right, if you think back to that idea of the balance between ecological flourishing and human flourishing, how can you have healthy, well people if we're utilizing all these resources in a way that's unsustainable in our medical practices? So, and at the same time, a lot of the work that I ended up doing was looking at, all right, so in end-of-life cancer care, you can actually find kind of a win-win-win situation, because, this might be a little utopian, but up to 90% of cancer patients who have been surveyed say that they want to die at home, but only 26% do. And a lot of that has to do with prognosis and the difficulty of prognosticating and the difficulty of having a conversation between the doctor and the patient that you're actually going to die. So if people want that information in certain cases, if we can help people get into these areas like hospice care, in my findings, hospice care had a much lower environmental footprint than conventional cancer care. If you can get people in that setting where they say they would prefer to be, you would actually have this win-win. People would be achieving their goal, and you would have a lower environmental footprint. So there's kind of a lot to that.
There's a follow-up on that. There's some really interesting stuff that Art Kaplan did, which was about the health outcomes of people in the aggressive nature of doctors in Europe versus in America, and how
they're leaching out of landfills and they're coming straight down the pipe when you're disposing of them. Or, I think the number is 70%. 70% of the medication that you actually consume, you pee out. So like a lot of the pharmaceuticals need to be better designed as well. And that's an area where green pharmacy is coming on. But it looks like, the conversation is saying that we're 20 years out from having the ability to design things so that your metabolism will be able to actually use all of it instead of excreting a large proportion of it. So those conversations are not in the current system for approving drugs.
I have a question on that too. I thought the drugs in Lake Champlain was a cool idea. So again, 2 things on that. When we lived in Washington DC, they made this incredible map of cocaine use in Washington DC by sampling the water, the sewage system at different points in the city, and they knew the kind of watershed that was drained at each point, and they could just say, we know where cocaine's being used more than others because everyone's peeing it out, right? Okay, so that's pretty cool. But Burlington's a town with a hospital in it, a big hospital, small town. So do you have any sense for how much of medical waste in water comes from hospitals versus anyone's bathrooms?
Yeah, that's a great question. So the thing that we have going for us in our study is that the hospital actually, their effluent goes to the Winooski River. So it's not the main treatment plant where we are collecting effluent. So we think we might be okay there on figuring out.
Hospital free.
We're hospital free.
Yeah.
But at the same time, we have an interest in getting over there and seeing, what's coming down the pipe from the hospital as well. Yeah.
Are they regulated at all, like any other pollutant source would be, in terms of what they can just flush away?
They're not regulated in terms of like amounts. There's like no TMDL for pharmaceutical. But there are the waste disposal regulations, and you're supposed to dispose of practically everything except the narcotics through incineration. So they have like these big black boxes. You put all the drugs in there. When you're in the pharmacy, when you're in the hospital, that's where it goes. But the narcotics are things that are still recommended to flush down the drain, particularly if it's in a liquid form. So yes, that's where the current regulations stand.
Okay.
Oh my gosh, wouldn't narcotics have a dramatic effect on the fish life?
That's why they're having problems going over the dam. Sorry.
So my understanding is that actually no. In speaking with pharmacists, they have said that because the narcotics they're a naturally derived product for the very most part, and they quickly degrade in the natural environment, they don't have a concern. They're less likely to persist than many other chemicals. And you've seen, there have been even recently, some new rankings coming out. EPA just had a study come out in September with like their top 50 ranked pharmaceuticals of concern, and narcotics are not on that list.
So I have another theory going along with the 2 that we've heard about why it is that hospitals are not more environmentally conscious and recycling and such, which basically is that the people with the power there are more interested in human health than what's happening elsewhere, and they have a very rigid environment because they're worried about sharps and diseases getting spread around. But I can't help but wonder if a director of sustainability wouldn't be able to find alternative ways of doing things that were much more ecologically conscious and responsible.
Well, 2 things on that, right? Like, we want our hospitals to be focused on our health. We don't want them to have to think about,
We don't?
Well, when you're a patient, you don't. So you want the system to be, this is my opinion, I think we want the system to be set up in a way that is supportive of the ecological environment.
Well, I think
You want your physician to be supportive of your health, maybe in a broader sense than the way that we are currently practicing healthcare. But you don't want your doctor to have to also know about where the nitrile gloves came from. That's out of their realm. And it should be, because you want them to be focused.
Yeah.
I wanted to mention the parallel with in the military and building military bases, because they are actually exempted from some of the environmental impact assessment that has to be done for other buildings. And they've gone through the same sort of debates about whether or not they need to be concerned with sustainability when they're trying to kill people as opposed to trying to promote health. But it's the same debate, and there the effects are more striking because they're not even responsible for basic environmental health assessments that are otherwise governed by other sectors of society, and that goes global. I mean, it's not just the fort that's built in Texas or Alabama, but global, every single base around the world. And they're allowed to use outdated technologies, they're allowed to, and heating systems. I mean, the basic standards that are required for appliances for everyone else in the United States do not apply to base behaviors. So,
Maybe one more question?
the same thing for prison industry too, actually.
I was curious, going back to mobility versus visibility, there's some interesting literature in consumer transparency, and that's what some of the stuff that I'm working on. Are those terms that you have individually developed? Because they're different than some of the way that it's framed in terms of consumer transparency.
Let's talk, yes. Because I'm very interested, like, this is a literature that I'm not familiar with. But yeah, I've not seen like these terms being used. This is something that my advisor, Mike Bell, and I had lots of conversations over when first kind of setting forth with this. And they are new to environmental flows, but I'd love to see what terms are being used and how they're being used, if they're being used in similar parallel ways or very differently.
There's also an interesting piece called the eco penalty, which is about consumer framing when it comes to safety, and about how consumers sometimes actually do not want eco labeling or eco positioning when it has to do with physical health, because they want it to be as strong as possible. And in some ways, the ecological impacts could actually reduce that in their mind. So there's actually some interesting empirical research that's been done in that area.
Which is great, because I think it speaks back to that question of, like, you want the overarching system to be set up in a way that is promoting of ecological flourishing, right, for lack of a better term. And then the day-to-day practice doesn't even have to think about it. It's just part of the system.
Agreed.
Yeah.
It seems really interesting to me that in this whole conversation we've been talking about it, of like green pharmaceuticals maybe reducing the ability of the drug to help people, and it's been pitting kind of like an environmental outcome against a human health outcome. But when I think of the examples that I just have heard about, it seems more like we don't need to pit those against each other, because you're really pitting a short-term, single-person health outcome against a long-term health outcome of an entire community if pharmaceuticals are building up. So it seems like you could potentially break away from pitting environmental health against human health by just saying, like, if pharmaceuticals are building up, we have a human health impact. Like, this is safe for the woman who takes the drug, but it isn't safe for women. And that has just a different feel to me than it has an environmental impact, which is, like, I completely agree with Bob, like, that's hard for me to even stomach. Like, you can't have this cancer treatment because of its environmental impact. Like, I think a lot of people really on a strong environmental mindset would have trouble with that if it was their mom getting treatment, right?
Absolutely.
But
absolutely.
We're making this an unsafe world for everyone. Like, you can see people compromising on that more anyway.
Well, and in that case too, like, trying not to pit anything against each other, but trying to look at things more holistically. Like, the evidence with the stage 0 breast cancer. The evidence shows that women they're just as likely to survive for the 15 years if you have this versus this.
So there's no human health sacrifice.
There's no sacrifice, and there's actually a potential benefit because of those other concerns from mastectomy. But so what are the things that are driving women and their physicians to choose this more radical, aggressive approach when it's not always necessary, right? There are those few situations where it is necessary, because of the specific histology of the tumor.
Yeah.
But for the majority of people who are receiving that treatment, it's not necessary. How can you change, how do you intervene in some way to provide better information or to reduce the fears that are associated with cancer? There was a great article out 2 days ago, actually the New York Times, there was a commentary, an opinion piece about the need to do a better, like an epidemiological study of medical care, because there's these cases where in Korea, we've seen in the past couple of years a huge increase in the number of thyroid cancer. Why is that? It's not because thyroid cancer is actually going up, it's because we've screened for early stage thyroid cancer. And these were cancers, if I remember correctly, this was another 70% of all people, all adults, have thyroid cancer. You just don't know it, and it never will cause you a problem. But we're screening for it really early because it's an easy screen to do. You just need an image of the throat, and then you can see it. So people are picking up on it at a very early stage. You're getting treatment, and then you have potential impacts on the health of that person, and environmental impacts, social impacts, economic impacts, all sorts of different components of it. Why is that? Just because of the way that we are focusing on early screening, early detection. And this article was suggesting that sometimes you don't want early detection. It's actually not going to improve things for anybody, even like the individual or society. So trying to get that bigger picture in there.
They've had the same thing with PSA and prostate cancer too. It's been huge.
Okay.
And it's funny, well, I mean, it's not funny, but my stepfather had his prostate out because his PSA levels were up. And of course now, 10, 15 years later, he's getting all the repercussions of having the prostate out, which he was, it's this whole weighting of risk and how that's communicated to, how doctors communicate that, etc.
Great point. Yeah, the communication piece, the risk piece. How do we handle those?
Are we really done?
I think we're probably done. Sorry. So we did start about 4 minutes late.
Thanks.
Thank you.